You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 2nd, 2019, otherwise known as the Polar Vortex, TWIC. This week, AF guidelines, PF closure, fried chicken, skipping breakfast, and smoking cessation. First story is the AF guidelines. This week, the AHA and ACC published a focused update of the older 2014 AF treatment guidelines. I am going to write a column on this topic, and it'll likely come out next week, but here is a brief summary of some of the changes. First, direct-acting oral anticoagulant drugs, or DOAC drugs, are now favored over warfarin, which is reasonable and similar to the European guidelines. Yes, the absolute difference in efficacy and safety of DOACs over warfarin are small, but the gains in convenience and probably adherences are quite large. Remember that Dr. Victor Montori from the Mayo Clinic is a lead advocate for minimally disruptive care, or that is, doctors helping patients decrease the work of being a patient. So if you just consider the work of being a patient with DOACs versus warfarin, it's a substantially more convenient way to prevent stroke. Second, aspirin is now out, but it's out in a weird way. So for patients with a CHA2DS2-VASc score of 1 or 2 in women, aka this gray area, the writers say that oral anticoagulation may be considered. Aspirin just simply isn't mentioned, nor is any statement that this is a big change from the previous guidelines. Female gender is no longer considered a risk factor unless it accompanies another risk factor. In other words, if female gender is the only risk factor, you don't say CHA2DS2-VASc score 1. Valvular heart disease gets clarified, thank goodness. Writers go back to what it was originally meant to mean, and that is moderate to severe rheumatic mitral stenosis and mechanical valve replacements. These are valvular heart disease. All other valvular conditions are not. AF ablation for heart failure is severely disrespected. Castle AF, an RCT comparing AF ablation versus medical therapy in patients with heart failure, found a massive 12% reduction in death and heart failure admissions respectively. This was published in the New England Journal of Medicine. Yet the authors of the guidelines give it a 2B recommendation, and I'll discuss this more in my column coming up. But the reason that recommendation is wrong is that it is the same level that's assigned to left atrial appendage closure either percutaneously or surgically. Now, percutaneous left atrial appendage closure has certainly essentially negative RCT level evidence, and surgical left atrial appendage closure has no RCT level evidence. Finally, in end-stage renal disease, apixaban is called a reasonable alternative to warfarin. Of note, I would add that there is a lack of RCT level evidence that any anticoagulation provides a net benefit to patients with end-stage renal disease. Second topic today, PFO closure. So the PFO trials can be grouped into two groups. The early trials, which showed no benefits of PFO closure over aspirin in patients with cryptogenic stroke. The three later trials did show benefit versus aspirin. The cited reason for this difference in the groups of trials is better patient selection. In the later trials, they selected patients with bigger shunts that had confirmed stroke, not just TIAs. Now, the truth is that the trials had low event rates, they had a not insignificant rate of dropouts, and we also know that aspirin is a pretty ineffective preventer of venous clots. So I think that although the later PFO trials were positive, I think it's far from certain that PFO closure is the superior option. Additionally, the PFO trials, like all cardiovascular trials, offer us only 4-year follow-up. When you close a PFO, this is a lifelong therapy. That's why the Journal of the American College of Cardiology published a small observational study of 201 consecutive patients who had PFO closure who had a median follow-up of 12 years. Nearly 1 in 5 of these patients actually quit antiplatelet therapy, so it was PFO closure alone. They found that 6% of these patients died, but all of non-cardiac causes. 7 of 201 patients, or 3.5%, had recurrent neurologic events, with 2 patients having a stroke, one due to atheroembolic disease and the other due to a vertebral artery dissection. All patients with neurologic events were on antiplatelet therapy. 13 patients, or 6%, had bleeding, and all were on antiplatelet drugs. Atrial fibrillation occurred in 5 of the 201 patients. So my comments on this is that this is real-world data, and sometimes that kind of data is useful. It's also worth saying again and again and again that most cardiovascular trials have only short follow-up, and most preventive cardiovascular therapies are for life. But I'm a little surprised that a leading journal like JACC took this single-arm, small observational study. The authors attempted to compare their stroke rates to those in the RCTs, but this, of course, is fraught with problems. And another problem in this PFO closure situation is that even with no therapy, the recurrent stroke rate of young patients with cryptogenic stroke is super low. You just simply need more patients, and you need randomization to know anything real. Finally, the safety or bleeding data on direct-acting oral anticoagulants, or DOAC drugs, suggest very similar bleeding rates to aspirin. So if we really, really want to know the answer of best therapy for cryptogenic stroke in the presence of a PFO, we need a trial of DOAC versus PFO closure, and I doubt this will happen. The third topic today is fried chicken. You'll never guess what transpired this week. A group of authors collected data from an observational study that looked at self-reported intake of fried foods, including fried chicken. Now, you all know that I live in Louisville, the home of Kentucky Fried Chicken, so of course I had to mention this study. A prominent medical journal published it, and prominent doctors commented on it. The authors wrote a highly refined manuscript. And you won't believe it. Sit down for this. Women who ate more fried chicken had higher hazard ratios for death and cardiovascular death. And my friends, I spend oxygen on this story only so that we can add fried chicken consumption to all of the coffee, tea, blueberry, and chocolate observational studies, which should stop as soon as possible. Of course, eating too much fried chicken is bad for you. The main question is, how can we stop wasting research dollars on these sorts of studies? Of course, you could argue that me mentioning this problem even worsens the problem. Fourth topic, let's stay on nutrition studies and go to breakfast advice. Most often, a grandmother's health advice is quite sound. Grandmothers say, eat right, exercise, and go to bed on time. However, breakfast being the most important meal of the day, that's maybe not such good advice. The thinking behind that strategy is that missing breakfast leads to overconsumption of calories later in the day. The BMJ published a meta-analysis of 13 trials that examined the effect of eating breakfast. And boom, there goes another health dogma. Skipping breakfast led to a small loss of weight of 0.44 kilograms, and participants assigned to eat breakfast ended up consuming more calories in a day versus those told to skip breakfast. Now, the lead author, Catherine Sievert from Monash University in Melbourne, refreshingly called for caution in the interpretation of this study, given the inclusion of lower quality studies in the meta-analysis. So I put this topic in the weekly recap because not skipping breakfast is still a part of the nutrition guidelines from the NHS, U.S. Agriculture Department, as well as Australian guidelines. Final topic today is a smoking cessation RCT published in the New England Journal. Now, it compared e-cigarette use versus nicotine replacement therapy for smoking cessation in nearly 900 young adults in the UK. The primary endpoint was abstinence from smoking at 1 year, and it was confirmed by biochemical testing. Here, the top-line results was that abstinence was 18% for e-cigarette users versus 9.9% for those using nicotine replacement therapy, and that's an absolute risk reduction of 8%, which is an NNT of 12, and that sounds like a big win, doesn't it? Well, as it is so often, the best analysis of this trial comes from Twitter. The vegan cardiologist Jim Stein points out that 173 individuals, or 40% of people in the e-cigarette arm, were still using e-cigarettes at 1 year. 79 or 18% of individuals in that arm had quit smoking, but of these 79, 63 or 80% had transitioned to e-cigarettes. And worse, 94 patients in the e-cigarette group had become dual product users. Now, said another way, for every 100 people that try to quit using e-cigarettes, 18 do quit smoking, but of those, 14 become e-cigarette users, so only 4 are actually nicotine-free. And for the 82 of 100 people who don't quit, 21 become dual users. That means that e-cigarettes create more dual users of nicotine delivery than true quitters. This, my friends, is not good. E-cigarettes are running rampant, especially among the young, and who knows the long-term effects of high-dose nicotine exposure. I suspect it's not good. More simply, my friends, e-cigarettes as a health intervention simply do not pass the mastery of the obvious test. So that's it for this week in cardiology. Again, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please consider subscribing, giving us a rating so that others can find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.